What's up, everybody? We're going to do another video. I know it's been a little while, so I apologize for that. I just tried recording this the first time around, and it was horrendously long and kind of boring. So, tightening it up a little bit. Hopefully, this goes a little bit better. We're going to be talking about waves today. These are going to be EKG waves. I will not be having any slides like this in the presentation. We went to a conference recently called SMAC. Let's try this. SMAC. And all the presenters there basically are not allowed to use slides like this because no one likes these kind of slides. So we won't be doing that. Moving on. First wave we're going to talk about is U wave. Everyone kind of knows what these look like. Uh, do not get this confused with a U wave. Different kind of U. This U is the most friendly U on the farm, apparently, on the website that I looked at. So here's the U wave we want to talk about. It is this upward deflection right here after the T wave. We're familiar with that, so we're not going to spend a lot of time on U waves. Here's a couple areas you can see U waves. The one we're most familiar with is down here with hypokalemia. But most commonly, actually, you can see U waves with bradycardia, which I was less familiar with. And also, a couple other areas you can see inverted U waves like this in ischemic process, kind of like inverted T waves. If you see an inverted U, it could be ischemia. And digoxin as well, toxicity. You can get this kind of down-up process. They call it T U wave, so T into the U. So not super exciting, so we're going to keep moving. We're going to go on to Osborn waves. Osborn waves, not these Osborns. Note the spelling difference here. But this is an Osborn wave. This is John J. Osborn, who got these waves named after him. I guess he did some research in the 50s with premature cold babies or something and noted these Osborn waves. Anyway, this is an Osborn wave right here. It's kind of a large Osborn wave. It's basically a very prominent J wave. So J wave is that little upward deflection right there after the QRS complex that you sometimes see with early repolarization changes that we see kind of on a lot of EKGs. That can be normal, but if it gets big, that's when you call it an Osborn wave. We think about this in hypothermia. So as you get colder, these Osborn waves get bigger. So you can see here 32.5, it's like, I think it was 90 degrees Celsius, something like that. You see a small Osborn wave here, and as the person gets colder, 30 degrees Celsius, I think it's 86 Fahrenheit. And then down here to very cold, 24.1. You need a pretty big wave right there. I mean, it also looks like almost looks like a right bundle branch block. It's so huge. But patients can do well with even this temperature, depending on the clinical picture. This was a case report in New England Journal where this kid lived after a couple hours of resuscitation or something. So I'm not going to talk much more about that, but coming up, we got cold weather coming. This article is awesome. There's a lot of stuff you can do when someone's cold or they are cold and dead but not warm and dead, and you're kind of wondering, what do I do with this patient? I know there's Foleys and bear huggers and chest tubes, and ECMO and dialysis, and it's sometimes hard to remember all that stuff. So this article, I recommend review it before the cold weather winter months are coming. So this is kind of why I wanted to put together this presentation is for a wave called epsilon wave that I was really not very familiar with until recently, but it's kind of one of those things that you're not going to see that often, but if you do happen to see it, you could maybe save somebody. So what's an epsilon wave? This is what it looks like right here. This is a really blown up picture, but it's those kind of little upward deflections, again after the QRS, and we'll see some more examples. But the reason that we want to know about epsilon waves is because they can be a sign of ARVD, arrhythmogenic right ventricular dysplasia, which is bad. This is rare. It's inherited a lot of times, genetic transmission. I think it's a dominant type of passage through the family. But does not have complete penetrance, so it might have a family history, but not everyone necessarily will have it. So what happens? Your right ventricle gets messed up. You have fatty infiltration and fibrous infiltration right in through here. This is a 17-year-old heart from a 17-year-old that died during a soccer game, sudden cardiac death. And you can see there's the right ventricle is just so thin, and there's only a little bit of muscle here when all the rest has been replaced with all this fibrous crap. So that obviously doesn't work very well, and you can have dysrhythmias, ventricular dysrhythmias, VTAC, and sudden cardiac death. So some of these diagnoses are made on autopsy. So what do you do when this death monster of ARVD, this is I swapped these letters but didn't feel like going back and changing it, is coming for your patient? Well, all you need are two things. You need your EKG, which is here, and this trident of magical powers. So moving on, we'll focus on the EKG part of it. There's a couple different things to look for in a ARVD EKG patient. So you're going to look for that epsilon wave that we just talked about. You're going to see maybe some two-wave inversions in lead V1 and V3, so the precordial leads. And you also see a prolonged S-wave upstroke. That's I'll show an example of that in a second. And lastly, it's messing up your right ventricle, so you could have a right bundle branch block or an incomplete right bundle branch block, so your QRS could be prolonged. So here's some examples of epsilon waves here. They kind of look a little different, but they're all in the same location, and that same little upward deflection. Boy, that circle was off center. Let's try again. There we go. Here, and here's some epsilon waves up here. You can see in this one here, you got your T-wave inversions and the precordial leads. And this down here is that prolonged S-wave upstroke. You see how it's kind of delayed and it kind of comes out a little bit more slowly than your normal QRS, which would be a little more narrow. So that you might see these things on an EKG. So you're probably thinking right now, I'm not going to remember all this. This is ridiculous. I'm never going to make this diagnosis. And maybe not, but one of us probably will at some point. So let's do a sample case to put it all together. Here's a patient that comes in, brought in by the parents, maybe a 17-year-old girl who had a syncopal episode during a soccer game. She says it's because she was dehydrated and it was a really hot day and they were doing a lot of cardio, which is why I don't do cardio. But anyway, you look at their EKG and you look at it and you're like, boy, this is really weird. Like, what's going on? Something's just not right here. And you can see here there's T-wave inversions diffusely. And you think, is this acute coronary syndrome? That'd be a weird presentation in this young, healthy patient. Is this a PE? I know T-wave inversions in the precordial leads can be PE sometimes, but doesn't have any respiratory symptoms. And then you look closer, and you can pick up potentially this epsilon wave. And at that point, epsilon waves are very specific for ARVD. So if you see one, you got to be real concerned that that's what's going on, and then you take the next steps of cardiology referral outpatient and don't do any activity exertionally, or maybe admit the patient if you're concerned. And then they go on to AICD placement and testing and potentially even a heart transplant if they need it, because there's really no cure for this. But maybe you could save somebody. This particular patient actually is Chrissy Taylor, who is Nikki Taylor, the supermodel from the 90s, her younger sister who was found collapsed at home, who basically suffered cardiac death, and on autopsy they found ARVD. So she actually did not have any preceding symptoms like palpitations or syncope, and so unfortunately she died. But delta wave, moving on. I thought this was appropriate time to bring up the elephant in the room with Delmer's delts. If you look at my delt here, you see it's kind of a well-proportioned, you got a nice V coming down there. That's what you want to see. But Delmer, although he's really got huge biceps and traps, his delts are very underdeveloped. So Delmer, you got to work on that. Here's delta wave here. We got the short PR interval, kind of that upsloping wave that we remember, and we think about WPW with this picture. So WPW is basically when you have a extra AV tract out here. Bundle of Kent is typically what it's called, and you can kind of bypass the AV node. So it's kind of an accessory pathway. Um, and what happens is you get a signal coming down from the sinus node, and it goes down here, and some of it goes down here. And the part that goes down the accessory pathway will pre-excite the ventricles, so they'll start depolarizing, and you get this early upslope right here. So what bad can happen with WPW? Well, we have seen or we hear about some of this, and you can get a couple different things that can happen. What can happen is you can get these fast rhythms, and they're called the AV reentrant tachycardias. So the mechanism of this is that normally you have the signals going down both tracks, like we were talking about before, and then they depolarize and you get the delta wave. And then these tracks are both in a resting state and they're recovering, and then you get another impulse that starts the whole thing over. So you get these beat after beat with the delta wave like we're talking about. What can happen is if you get these two tracks can rest and recover at different rates. So if you get an early beat like a PAC, the PAC comes down, and let's say that this accessory pathway is still resting, but this AV node is recovered. So the impulse will go down the AV node. It will go down, depolarize, you'll get a beat, and it'll come back up and keep going. And now this accessory pathway has recovered, so it can go back up retrograde through this pathway and then come back around this way. And then by now the AV node is recovered again, so it can go down again, and then this way, so it just goes circle, circle, circle. Goes fast, and you get this rhythm right here, which looks like one of our SVT rhythms, which we're going to treat just like we treat SVT with adenosine, cardizem, all vagal maneuvers, all that kind of stuff. So this is one instance in WPW we can actually use all the normal drugs we would use for SVT. What also can then happen is you can have a early beat, and the AV node is the one that's still resting, and it can conduct down this pathway that's recovered already, if this one happens to be a faster recovering pathway in a particular patient. And it'll go down this way and go conduct back up, and now this is recovered, so we go backwards and make a loop like this, in which case it's going backwards conduction through the AV node, so you actually get a wide complex tachycardia out here. This is called the antidromic pathway. The pathway up on the top is orthodromic. So for these wide complex tachycardias with WPW, if you really knew the patient had WPW and you knew for sure that this is WPW and not VTAC, you could actually treat with all the normal medications that you would for like an SVT. But realistically, you're not always going to have that information. It's going to look like VTAC to you. So you're probably going to treat this patient alternate with amiodarone, or you can always shock them. Procainamide would be an ideal choice, but we don't really have that in our emergency room. It's just like droperidol. We haven't had it for 3 years. So the last one down here on the bottom is the one that you really become concerned about, and this is kind of the nightmare patient with WPW, and that's WPW with AFib. So now you have just showering impulses from AFib going down this pathway, going down this pathway. It's fast, it's irregular, it's a complete mess, and then get rates up to 300. This is the patient where you do not want to use any of your AV nodal blockers like calcium channel blockers or adenosine or beta blockers, because that can slow your AV node down, and preferentially all these showering impulses will go down this fast pathway over here, and you'll get rates of really fast. So that's AV reentrant tachycardias, WPW. Real quickly, AV NRT, so note the difference, AV nodal reentrant tachycardias, you can get a similar loop just like we had in the last one, but without an accessory pathway. So this is a patient with a structurally normal heart, but have two pathways actually in the AV node. So it's inside the AV node, but you get the same loops like you're talking about before. And in this patient, these are the patients we actually kind of more commonly call paroxysmal SVT patient, which is the rhythm down here. So what we call paroxysmal SVT, you could, the majority of the time is actually an AV nodal reentrant tachycardia. We're getting this reentry, and all that circular loop is occurring in the AV node itself. All right, that's about it for today. A couple last waves for you. Waylon, here's your boy. I know you're pumped. If anybody has any questions, let me know. I went through this quickly, but hopefully it'll give something of a review and something of maybe learn some new things here. And I will see you all later.